So we're ready to begin this next session entitled Risk Reduction and Early Detection Updates on Breast Cancer Screening. So we have three very outstanding speakers. Dr. Karla Kerlikowske is a professor of medicine and professor of epidemiology at the University of California, San Francisco. We'll be discussing risk-based screening of the average population. This will be followed by Dr. Connie Lehman, who's professor of surgery at Harvard Medical School and Massachusetts General Hospital. We'll be talking about novel imaging modalities. And finally, Dr. Seema, who's professor of surgery at Northwestern University, will be discussing screening for high-risk women, the clinical perspective. So what we're going to do is we're going to have the three talks in sequence with no questions in between, but we'll have questions and discussions at the end. So we'll begin with Dr. Karla Kerlikowske talking about risk-based screening in the average population. Karla.
Thank you, and good afternoon. I always like to mention this, that for my disclosures, that I'm a primary care physician. So that is my perspective in interpreting these data and in the implementation of the data. So it's easier to describe who's average risk women by who is high risk. So for instance, average risk women do not have a personal history of breast cancer. They haven't been previously diagnosed with a high risk lesion. They don't have a genetic mutation, and they haven't been exposed to radiation. So the women I'm going to talk about are everyone else but those people. So why should we do risk-based screening instead of age-based screening? And really, the goal is to try and maximize the benefit of screening and minimize the harms. People might frown when I say that, but mammography is kind of just an okay test. And because it's just kind of an okay test, we really should be doing targeted screening to maximize that benefit and minimize that harms. And the harms in particular are high for people who are low risk. And of course, we can improve on costs because the more mammograms you do, the more it costs. So I'm going to focus on two particular ways that risk can be applied to screening. One is when to start screening, and then screening frequency and supplemental imaging. It's a little sensitive, this thing. It's not moving. Oh, there we go. So this is the current state of affairs as far as age-based screening. These are the U.S. Preventive Task Force most recent data produced by the CISNET Breast Cancer Modeling Group. And you can see that the number of deaths averted by screening 50 to 74, or 13 mammograms during that period, you only avert about 7 breast cancer deaths per 1,000. So it's not a lot. It's some, but it's not a lot. And you can see that there's a fair number of false positive biopsies and false positive recalls that you get with screening. What I always find kind of interesting is that the number of overdiagnosed are greater than the number that deaths averted from breast cancer. So you can see there's a little bit more benefit from annual mammography, but not much. And for women 40 to 49, about 1 breast cancer death averted per 1,000. And again, not much difference between annual and biannual. I don't know why this is not moving very well. Oh, there we go. But just to give you a sense of the false positive, how much it is, this is a study we did within the Breast Cancer Surveillance Consortium. And you can see if you do annual mammography, whether it's digital or DBT, a woman's chance of at least 1 false positive is almost 50%. So annual screening results in a lot of false positive tests with not any or marginal additional benefit as far as decreasing breast cancer deaths. You can see that DBT improved the recalls a little bit, and you'll hear this quite a bit in the literature, but it's, in my opinion, it's not like knock your socks off. A lot fewer recalls, and particularly if you do annual screening. And you can see for biennial, there's very little difference. And for false positive biopsy, again, do annual screening, you'll get more false positive biopsy, and biennial, it's fewer and really no difference between digital and DBT. So we really can do better than this, I think, and that's the goal of sort of doing a risk-based screening. The other, I think, reason we should start doing more targeted screening is that treatment has gotten super good. And the contribution of screening to decreasing breast cancer mortality in this study published this year in JAMA is only about 25%. So if we really want to improve on that, we need to target women who are at high risk of aggressive or advanced disease. What I was heartened by this particular slide is that there's been great achievement in decreasing metastatic death, decrease in breast cancer death from metastatic disease, and I was very heartened by that in this slide. So what about risk-based screening? Can we use it to guide when to start screening? One of the important things is that you need a risk model. There are general risk models, and there are more high-risk models. So as I mentioned, we're talking about an average risk population, so we're more interested in the general models. The first is the Gale model, which most people are most familiar with as probably the first model. There's the Breast Cancer Surveillance Consortium Invasive Cancer Risk Model. It has 5- and 10-year risk, and then the Kerlikowske model. And my colleagues in the audience who did this study where she compared the models in the US population, and you can see that the calibration and discrimination is highest for the BCSC 5-year risk model, not quite as good for the Gale model or the Kerlikowske model. I think part of the reason it's not as good for the Gale model does not include breast density. And breast density is a strong risk factor, but most importantly, it's very prevalent. So when you have a strong and prevalent risk factor, it can contribute to the development of breast cancer. The reason I think the Kerlikowske model did not perform well as far as discrimination and calibration is because it was developed in white women in the UK, where our breast cancer surveillance consortium model, when you apply it to the US population, it is representative of urban-rural, economic, and racial ethnic distribution. So it kind of makes sense that our model should perform better in US women. So how do you decide what risk factors go into a model? And you can see that this is what we call the population attributable risk. So how much if that particular risk factor contributes to the development of breast cancer. And you can see that breast density for premenopausal women, if we could make them all have either fatty or scattered fibroglandular dense breast density, we would get rid of 29% of breast cancers. So the population attributable risk is a good thing to look at when deciding which risk factors you want in your model. And you can see that breast density has a high population attributable risk. BMI, obesity, has a high population attributable risk for postmenopausal women. And the other factors we always kind of think a lot about, like family history, are kind of modest or low population attributable risk. But when you add them all up, it's about it accounts for about 43% of breast cancers in postmenopausal women. We just released this model. It's a new model, and we added body mass index just because of our study on population attributable risk. We also added age at first live birth, mostly to better identify low-risk women, because if you have your children young, it decreases your risk of breast cancer. So this is our model. Let me just say you can download it on your iPhone or Android phone for free and kind of play with it. It shows you what the risk is for your patient, but it also shows you someone who is the same age and race, sort of the average risk for that woman. So I think it's the red is your patient and the blue is the more average risk. I don't know why. Oh, there we go. So I love this slide. This is my favorite slide I always show. Basically showing that what is the distribution of risk in women 40 to 49? And to me, this alone is good information of why we shouldn't screen everybody the same. So you can see that if you have fatty breasts and you have no history of any risk factors, your risk of breast cancer in the next 5 years is 0.3%. Where in the other corner, if you have extremely dense breasts, you're obese, and have a family history or a history of biopsy, your risk is much higher at 2.3%. One of the sort of major points on this slide also is that if you have fatty breasts, no risk factor will increase your risk of breast cancer. It's like you're impenetrable in some ways. So fatty breasts really protect you against increased risk of breast cancer. Now, all the numbers in blue, I'm trying to get this to work. All the numbers in blue are the risk higher than a 50 to 59-year-old woman. So a 50 to 59-year-old woman has the average risk of 1.4 or higher. So you can see that those numbers bolded in blue are people who have a risk of a 50-year-old or higher. But you can see, even for scatter fibroglandular density, only people who have family history and biopsy will reach that risk of a 50-year-old. And then for C and D, you can see just having one risk factor increases your risk. So what I do in my clinic as a primary care physician for 40-year-olds, if they have one first-degree relative with breast cancer or a history of breast biopsy, and they're interested in getting screening, I order the mammogram, determine their breast density, calculate their risk, and if it's 1.4 or greater, I continue screening, and if it's not, then I wait until age 50. This approach of looking at the risk of a 50 to 59-year-old has been embraced by other countries. So at one point I thought, oh, I'm just in my little office thinking about this, but it's other countries are taking this approach too, again, to maximize the benefits and minimize the harms. So in Germany, they use the risk of a 50 to 59-year-old, and you can see that they decided on this 1.7% risk, and it equates to 282 screening 40 to 59 to detect one cancer, and it's very similar to the 50 to 59-year-olds at 292. So they really based it on, basically on risk or cancer detection. So that's Germany. Also in China, this is a very cool study, they looked at 10-year risk instead of 5-year risk. And you can see the general line of age 50, that's if you did everybody. But you can see, look how many are low risk. 58%, you wouldn't start till 55. Medium risk, you'd start around 48, that's 37% of the population. And then that really high risk group is really quite small at 5%. And then the last group is in Spain. They actually took our BCSC risk model and said if we screened everybody 45 to 74 every 2 years versus taking a risk stratified approach where some people were screened every 3 years, every 2 years, or every 1 year, how did that affect the outcomes? And you can see that, of course, it would decrease false positives, right? Because you're doing fewer screens if you're screening some women every 3 years. Also decreased overdiagnosis. But I was really interested in the fact that it decreased false negatives. That's because some of these women being screened every 2 years probably should be screened every year, but you need to identify who those people are in order to decrease their interval rate. Well, what about how often to screen? We were just talking about this, and supplemental screening. I think the supplemental screening in particular has become a big issue with the federal law on breast density. So I'm going to try and convince you that measuring advanced cancer risk is what should drive screening frequency and supplemental imaging. So just to review briefly, the federal law came out that you should report dense or not dense to women. It's a large population, 47%. We know 47% of those people don't get breast cancer and 47% don't need supplemental imaging. So who's at high risk and should get supplemental imaging? About 50% of women with dense breasts are low to average risk. So we know at least half the population we don't need to offer supplemental imaging. We did 2 studies looking at high risk of a missed cancer and high risk of advanced cancer, and about a quarter of women who have dense breasts are at increased risk of both of those. So this is my favorite slide. My goal is someday to meet Mr. Autier, because I love this slide that he made. Why do we pick advanced cancer risk? Advanced cancer is a surrogate for breast cancer mortality. This is data from the randomized controlled trials, and the trials that saw a reduction in breast cancer mortality saw a reduction in advanced cancer. So since breast cancer mortality it's very rare, even advanced cancer is pretty rare, but less rare than breast cancer mortality, we decided to focus on advanced cancer for our model. The other reason we decided to look at advanced cancer, this is again data from the Breast Cancer Surveillance Consortium, is that advanced cancer does not track with incidence. So you can see that for women, Black and white women, their rate of cancer is about the same, but for Black women, the risk of advanced cancer is twice as high. Whoops. Let's see if I can successfully go back. Yay, okay. Where Hispanic women, their risk of advanced cancer is almost the same as white, but they're at much lower risk of disease. So by focusing on advanced cancer, we're really going to target women who basically need the most help from more frequent screening and supplemental imaging. So how do you define advanced cancer? When we first started this, there were so many definitions out there, we had to decide which one to pick. So we looked at anatomic stage 2B or higher, we looked at pathologic stage, and we look at TMIST. And you can see the prevalence of those in our BCSC population. When we looked at death, how well those predicted death, prognostic pathologic stage predicted death the best. I mean, anatomic is not bad, but prognostic pathologic stage had the best association with breast cancer mortality. When you wonder who is getting advanced cancer, it's not just people with interval cancer. There are interval cancer models out there predicting interval cancer, but the problem with that is that, for me anyway, is that a lot of those women have early stage disease. They don't need supplemental imaging, right? It's those people with advanced cancer who have lower survival at 77.4 or screen detected at 85.4. So we are really focused on prognostic advanced stage, whether it's screen detected or interval. And you can see about 41% are screen detected and 59% are interval. Our model has risk factors very similar to the BCSC risk model. We don't have second-degree relative or age at first live birth. But most importantly, we have BMI and breast density, which, as you saw on the previous slide, are strong risk factors for breast cancer. And we had the AUC of our model is pretty good, comparable to other average risk models. So when you apply this to a population, about 69% of women can get biannual screening because they're very low or average risk of advanced cancer. There are women, though, who are at intermediate risk with biannual, but if you look, they're average with annual. And when you look at our model, we call it an actionable risk model because it'll tell you, what their risk is based on what screening interval you choose. There are people that are so high risk that even with annual or biannual, they're at high risk. And these are the group, the 17%, that probably should get supplemental imaging. So since almost 70% can get biannual screening, you obviously don't need to do the advanced cancer risk model in every patient, unless you just, have fun and like to do risk models. So these are the factors that put people at highest risk of advanced cancer, and one alone will not get you there. So it really takes two risk factors, age 60 or older and obese, or age 60 and older and dense breasts, to reach that level of having intermediate or high advanced cancer risk. This model's free also. You can download it on your iPhone or Android app, and you can see, you can change for annual versus biannual and see how people's risk change. We recently looked at this actually in the BCSC in women getting supplemental ultrasound that had dense breasts. And we were heartened to know that the model performed pretty well, and people who are high risk, we really identified the highest cancer detection with our advanced model. Where you can see the BCSC model, it was quite noisy. So if you focus on advanced cancer, I think for supplemental imaging, you'll find those people at highest risk. We are also looking at AI measures, and I could only find 2 studies that looked at advanced cancer, and in particular, advanced prognostic cancer. This is a study that I did with Celine Vachon from the Mayo Clinic, and you can see that what I find kind of interesting is that the AI does pretty well at predicting, advanced cancer. So we're looking to see, we have a study right now looking at different AI models and how it would predict advanced cancers, both separately, but also within our model. Okay. Okay. I think I think we spend a lot of time focusing on imaging, but I can just say as a primary care provider, primary prevention is still key, and sometimes I feel like we forget that with breast cancer. And so I'm hoping to encourage all you to add that to your armamentarium, whether you're doing risk assessment or offering screening, that primary prevention still matters. Okay, so this is population attributable risk for advanced cancer. And you can see that for breast density and BMI, for BMI in postmenopausal women, it's over 30%, and in premenopausal, it's 22%. So overweight and obesity contribute to advanced cancer as well as breast density. This is kind of a fun thing on this slide, but you'll see over in the corner, screening interval. Screening interval does not make much difference. You get a 2% additional decrease in breast cancer mortality if you screen annually versus biannually. So very small and kind of in support of what the CISNET model showed. There is some difference, I wanted to, by race ethnicity. In particular for BMI, it seems to impact Black and Hispanic women more. So focus, trying to get them to decrease their weight, to decrease their population attributable risk. And it's really, it's higher for postmenopausal women, but even for premenopausal women. And for breast density, it's really highest in premenopausal white and Asian women, and in postmenopausal density, it's white women. So I always have this mantra when I give CME talks, trying to have people maintain ideal body weight will decrease the risk of advanced cancer. Alcohol in moderation. I had a resident do a study showing that alcohol is a mediator for breast density. So the more people drink, it increases their breast density. Exercise regularly, although I don't know that that necessarily decreases advanced cancer risk, but it's good for you. And then postmenopausal E+P for 5 years or less, particularly in women with dense breasts. So we did show a study that if your advanced cancer rate is higher if you have dense breasts and take E+P. So really trying to do that in moderation for that group would be good. So to summarize, age-based screening, I'll say, has a modest impact on averting breast cancer deaths, and it does result in significant harms. Risk-based screening maximizes the potential benefits and hopefully minimizes the harms of screening. You can use our BCSC 5-year invasive cancer risk model to decide on when to start screening with that 5-year threshold of 1.4%. Our 6-year cumulative advanced cancer risk model can inform optimal screening frequency and need for supplemental imaging. And then lastly, to really reduce invasive cancer and advanced cancer requires both primary and secondary prevention, not just secondary, which I think we tend to focus on. Thank you.
Thank you, Karla, for that very excellent presentation. And again, we're going to save questions for the very end. Our next speaker is Dr. Connie Lehman, professor of radiology at Harvard Medical School and the Massachusetts General Hospital.
So, good afternoon. Great. So I'm going to follow up on Karla's talk on exploring novel imaging technology. These are my disclosures. And what I'd like to do is first review the actual imaging technology, mammo, ultrasound, MRI, contrast-enhanced mammography, molecular breast imaging, sort of the tools that have been advanced. But also, I couldn't possibly give this talk without talking about the AI applications in image interpretation, which is a whole domain of advanced imaging discoveries. And then we'll end with the future of breast cancer screening with AI. So, in the domain of novel imaging technology, our implementation, sort of who and when, has not really kept pace with our technology innovation across the last more than 50 years. When we think about the incredible advances from our very crude methods of mammography and the early trials that were done on the impact of screening mammography, moving through to film screen and digital mammography, the experience for the patient has remained roughly the same. They're still compressed. We have radiation involved in the test, 2 views of the right breast, 2 of the left, and even most importantly, how we screen hasn't really changed. So this is a poster from the American Cancer Society in the early 1970s when they were trying to encourage more women to be screened with mammography. And the statement is, if you haven't had a mammogram, you may need more than your breasts examined. This poster was start at 35. Since then, we've had changes from 50 to 45 to 40. So really the sophistication we've used in who should be screened, at what age do we start, how often do we screen, and with what test do we screen them with, has really lagged behind the incredible advances in the technology itself. So I thought we would use the American College of Radiology and their appropriateness writings to really run through the different imaging technologies, both those that have been around for 50 years and those that are more recent, to really get a better understanding of where we are in novel imaging. And you can see under the procedures the American College of Radiology list, in addition to your standard 2D mammogram, what else might a patient be interested in? So they have 3D or tomosynthesis, ultrasound, mammography with IV contrast, MRI both before and after contrast, and MRI can be categorized as either our full MRI or our abbreviated or fast MRI. They also list MRI without contrast and molecular imaging. So these 9 different procedures that I'm going to collapse down into a shorter list and then walk through them. Also, what the American College of Radiology does is they assign an appropriateness criteria. They don't make strong recommendations on you should do this test, you should not do that test, but instead they've adopted a language and a color system where green is usually appropriate, and that really does mean we think it's a good idea for you to do this. Red is usually not appropriate, and that really translates to there's no reason to do this test in that particular group of patients. And yellow is we're really not sure. We had a committee, we couldn't get to agreement. It might be appropriate. We're still in a domain of case-by-case decisions and future exploration. And who may benefit, it's clear from the American College of Radiology, is as important as the technology itself. And the who at this time from the ACR is based on risk and density, 7 different variants of patients. Let's run through those. Variant 1, your patient has average risk and they are not dense. So they're categories A, fatty, or B, scattered. And in this domain, the American College of Radiology says, usually we think it's a really good idea to do a 3D mammogram. And so that's just a statement by the ACR that the new mammography in the US is tomosynthesis, or 3D mammography, rather than our more traditional 2D mammography. But nothing else should really be considered as reasonable in an average risk patient that is a category A or B density. But if you move into heterogeneously dense, and especially with the recent federal legislation, they then start to say, maybe we should be thinking about supplemental imaging in patients with heterogeneously dense breast tissue, even if they are at average risk. And at extremely dense, then the American College of Radiology moves into, we actually think these patients would benefit from MRI. So 3D tomo with MRI. They then move into the intermediate risk category of patients. I'm going to cut to the chase with 3D tomosynthesis. That's going to be green for every single variant, so we won't have to go into that more. And I'll also cut to the chase with the bottom category of molecular breast imaging. They never think it's appropriate in a screening situation. So those 2 bookends are going to be always never, and we're going to focus on what's in between. So this is the first time that we're seeing, maybe an intermediate risk and not dense, maybe we should consider MRI. Once we move into variants 5, 6, and 7, the recommendations are all the same. So patients that are intermediate risk but heterogeneously dense, or intermediate risk and extremely dense, or high risk any density, A, B, C, or D, the recommendation is 3D tomosynthesis with MRI and consideration of ultrasound or CEM. I really want us then to break this down, where we are now in these recommendations and where I think we should be and where we're headed. So if you took all of those together, you realize that if your patient is extremely dense, they will recommend MRI across the board, regardless of risk. And if your patient is high risk, they will recommend MRI in conjunction with 3D tomosynthesis across the board, regardless of the breast density. And then each of these cells represents a different type of patient. But MRI is clearly the supplemental test being recommended at this time by the ACR based on density or risk. And the only group that is not even a question of supplemental testing in the ACR appropriateness criteria is your non-dense patient at average risk. So 3D mammography for everyone, and molecular breast imaging for no one in a screening setting, with lots of questions around contrast-enhanced mammography and ultrasound. So that's what we're going to focus on. And again, for those of you who are in practices where they may be doing molecular breast imaging, because there are subgroups scattered around the country that are doing this, the reason the American College of Radiology doesn't recommend this is several factors. One, it's just a question of access. The infrastructure needed, if you imagine our country and all the healthcare deserts and how difficult it's been for us to get mammography vans and mammography centers scattered across the US. If you try to change all of those screening centers into centers fully equipped to do nuclear medicine, it just isn't feasible. The cost and the access are honestly just a deal breaker. The radiation concerns also are significant. For a sestamibi exam, the dose will be 2 to 5 times that of a mammogram. For PET or PEM, it's going to be 5 to 10 times. It's just not a good screening tool, and the reason why it's not recommended in the screening center. It has fantastic applications in the diagnostic and treatment domains, but not in the screening domain. So the FDA cleared breast tomosynthesis in 2011. For the patient, it's roughly the same exam. They're going to go in, the unit looks the same. The unit can take either a 2D or a 3D sweep of the breast. The breast is still compressed. We have centers, the difference for the patient is the gantry is actually going to move, so they need to remain still while that sweep occurs through the breast. Multiple projection images are acquired during that sweep. The same image acquires either the 3D sweep and a 2D snapshot, which would be a combo exam, or just the 3D sweep. And from that sweep, a 2D synthetic, sort of 2D-like mammogram is obtained. So often centers aren't sure, and patients aren't even sure if they had a combo or a 3D only, but those are distinctions that we see. And that's really varied. There are some radiologists that still really want the 2D acquired. They're not comfortable with the quality of the synthetic images. Others decided for for a variety of reasons, they'll no longer acquire that 2D snapshot and they'll use their synthetic view. And certainly once we start using 3D tomosynthesis, it would be very hard to go back. I'm old school, so I still focus first on my 2D or 2D-like exam, but going through those sweeps, honestly, I think what it helps me most on is clarifying overlapping tissue as benign and reducing my recall rate. But it's also great when you see something that's fairly subtle on your 2D, and then you scroll through to that slice and see a very clear spiculated mass. Our improved ability to see distortions is significant with tomosynthesis. So 3D may be better, but really there's wide variation across radiologists. And I always find it's sometimes difficult to give talks because people want me to show a chart of here's the sensitivity and specificity for fill in the blank of the technology the person's interested in. There's such wide variation. It really matters on the patient population being screened, and it matters on the radiologist interpreting the image. And Sally Friedwald published this, which was fantastic, early in our adoption of tomosynthesis. And while overall the specificity improved and the sensitivity improved, what I loved about this figure she included was just showing the heterogeneity across all the different sites. So this isn't even individuals, but actual imaging centers and their experience with 3D. So we had some centers that had no change at all in the sensitivity and specificity of their screening program after they switched from 2D to 3D, and some that actually went in the wrong direction, increased their recalls and decreased their cancer captures. So it's the variation that we pay attention to as well. European and Canadian national screening programs remain largely 2D at this time, so they have not made the transition to 3D, while the US market is almost all 3D at this point. So whole breast screening ultrasound. When we talk about screening ultrasound, by definition, it needs to be whole breast or we wouldn't be screening. This was the Wendy Berg Akron 666 trial. The physicians performed all of the handheld ultrasounds and found 4.2 additional cancers per 1,000 women screened, above and beyond the mammogram that was obtained. But that added cancer detection came with a cost. False positives increased, they about doubled, and also the cost of time. So for many practices, it just wasn't feasible to need a physician to spend 20 minutes doing an exam in a screening setting. It can read, in an hour, many screening mammograms, many screening MRIs, and the idea that they would be doing 3 screening ultrasounds during that hour just wasn't going to be feasible. So then automated whole breast screening ultrasound was presented as a solution to some of the challenges of handheld physician screening ultrasound. It's a 3D volume of the breast obtained and stored, and we now have separate image acquisition from the interpretation. So radiologists could go back to reading batches of these exams rather than needing to be present at the time of acquisition. This is the patient's experience. She's lying on her back. The transducer is very large, so it covers the entire breadth of the breast. And then this is all captured, the 3D volume, and presented to the radiologist. Many studies have been done. There's equivalent diagnostic performance between automated breast ultrasound and handheld ultrasound. I actually love ABUS. We've been evaluated, not as a screening tool, but as a diagnostic tool. We evaluated it at Mass General. And I think particularly for the coronal view, which is shown here, this is as if you are doing a physical exam of the patient. This is the nipple. You can see the gray fatty tissue, the white glandular tissue. Here's the lesion that's being palpated or felt. This was in a diagnostic setting. And then, so for the clinician, imagining the clinical exam they're doing and comparing that to the coronal views, it's a much closer one-to-one comparison with the full view of the breast available to them. For the radiologist, we have then that 3D volume is split, and the transverse image is very similar to how we capture our handheld ultrasound exams. So that's true whether it's a small cancer where you have a large domain of breast tissue all around this small cancer to evaluate in addition to the focal lesion on the ABUS, and then shown here is the handheld ultrasound equivalent. In our study, we were able to do many of these comparisons because the suspicious lesions would go to biopsy, and we could compare and contrast the handheld to the ABUS. And it's very good at also identifying benign simple cyst and not warranting further workup after the automated breast ultrasound. So why isn't everyone doing ultrasound? It's because the added impact of that added 2 to 4 cancers per 1,000 is absolutely swamped by doing vascular imaging. So if you're going to do supplemental imaging, you're not going to want to have to pay the price of the added time, the added cost, the false positive exams for patients to find 2 to 4 cancers per 1,000 when you can bring in vascular imaging and significantly increase that cancer detection rate. So this was Wendy Berg's follow-up to the Akron 666 trial. And if you just look at the areas I've highlighted, what we see is mammography alone, and this population in Akron 666 was slightly increased risk. So mammography alone finds this number of cancers. Adding ultrasound as expected raises that, 8.7 up to just over 11. But when you add MRI, now you're in the 20 per 1,000 range. So you are going to really find those small cancers that are enhancing and are not yet evident on a mammogram or an ultrasound. And she also presented that if you're doing the combination of MRI and mammography, there is no added benefit to adding ultrasound into the mix. So that is why we see in that chart with the ACR appropriateness criteria, it's just sort of swamped with MRI with question marks next to the ultrasound. So vascular-based screening, we are very fortunate. We have more than MRI. We'll look at the MRI data, but we have contrast-enhanced mammography and then the molecular breast imaging. Christian Kuhl early on showed very similar findings to Wendy Berg. It has been such stable findings across the US, in Europe, in Canada. What happens when you screen the same population with ultrasound, with mammography, and with MRI? MRI is clearly the lead, and the combination of mammography and MRI is the reasonable choice in patients that have been designated as appropriate for supplemental imaging. Janice Sung at Memorial Sloan did a beautiful study because she just reminded us all cancers are not the same. The green bars are MRI. Now, MRI is going to win over the red bars mammography in every subgroup, whether we are looking at low-grade DCIS or high-grade invasive cancers. MRI is seeing more of these cancers than mammography. And as you move from left to right, from low-grade DCIS up to high-grade invasive carcinomas, the sensitivity of mammography decreases while the sensitivity of MRI increases. And combined, MRI and mammography, the sensitivity is well over 95%. So again, further support for this combination of mammo and MRI in the appropriate select patients, which is why the American Cancer Society supports MRI as a supplemental test in women at significantly increased risk of breast cancer. So then, with the Breast Cancer Surveillance Consortium, investigators, including myself, had the opportunity to say, well, how is this permeating the community practices? How are we doing out there? If we've all agreed this is how we should screen women, what's actually going on? We had the ability to have 1.3 million mammograms, 9,000 breast MRIs. It gives us a sense also of how few MRIs are done in the full screening mammography population. And what we found, which was pretty discouraging, 75% of all screening MRIs performed were in women with less than 20% lifetime risk of breast cancer. And of women who were greater than 20% lifetime risk, less than 2% had received an MRI. So we were not implementing this in the way we had hoped. Another study found very similar results, 350,000 women with mammograms, a minority had had an MRI. 17%, only 17% of all screening MRIs were guideline appropriate. So the vast majority were being performed outside of the guidelines. Only 6% of women who met guidelines had received a screening MRI. So then we thought, well, maybe we need to change the test. Maybe we need to address access and cost and patient acceptance. Let's try to make the MRI experience better. One way to make it better is to make it shorter. So people came out with abbreviated, fast, ultra fast, super fast, but it was all this concept of making it a better experience for the patient and reducing the scan time and hopefully having that translate into reduced cost. As we thought about this at Mass General, we realized that each sequence is only about 2 minutes. So we wanted to retain the ability on our fast MRI to still look at the kinetics of lesions over time. We felt that was really helpful. And we also really liked our pre-contrast T2 or bright fluid sequence. So we developed a protocol called RAMP, or our Rapid MP protocol, which retained all the basic elements of a full breast MRI, but the acquisition time was under 10 minutes. And we found that this performance was equivalent to the performance of our much longer MRI protocol. So pretty much everyone is switching over to abbreviated or fast MRI. It's why I collapse the MRI case in the ACR appropriateness criteria, because I don't think, honestly, there's really a reason to do the longer MRI protocols when you can do these shorter protocols. Chris Comstock and ECOG Akron then wanted to perform a trial comparing an abbreviated breast MRI, which they defined as the acquisition is under 10 minutes, to digital breast tomosynthesis in women with dense breast tissue. It was a terrific study, and it confirmed what we believed would happen because of our knowledge of vascular imaging with MRI, that an abbreviated MRI far exceeds the cancer detection rate of mammography with DBT. But it was really just the precursor to the trial that Chris Comstock really wanted to do, which was what about contrast-enhanced mammography. We were thrilled that the ACR and the BCRF and GE Healthcare supported a trial to evaluate the use of contrast-enhanced mammography for screening women with dense breasts. We were so excited about this trial. And I think that modern contrast-enhanced mammography with iodinated contrast can definitely replace breast MRI with gadolinium contrast. It is a very cool test. So we have, the woman goes in, she's positioned as she would be for a regular mammogram, and before that positioning happens, she's given IV iodinated contrast, and then 2 images are obtained, one low energy, one high energy. Now the high energy can show you, as we see here in the middle image, glandular tissue, but it also shows that iodinated contrast. And when you subtract the 2, you get an image like this, where the iodinated contrast really pops out of the image. So for the patient experience, here's the contrast injection, positioning, low energy, high energy, release the compression, positioning the next breast, and then you walk through those 4 views. The whole exam, starting from the contrast administration, takes about 10 minutes. The images are beautiful, and thankfully we have a lot of research on the performance of this. So what are the take-home messages when we compare CEM and MRI? This sensitivity is very similar. There's a learning curve. There's a bit of heterogeneity in the studies that have been done to date, but very similar sensitivity. CEM has improved specificity. CEM can be is preferred by the majority of patients. They would much rather go to their mammography screening center, be out in the open air, not in the MRI scanner, and have the IV with a 10-minute exam. Significant cost savings. So then what happened? Because this isn't really that new. John Lewin had published on the early CEM exams in 2000. Why didn't we have uptake? I think we still lack a feasible payment structure for CEM, and people are really reluctant to let go of MRI without having more reasonable payment structure in place. Those groups that are doing CEM tend to bill as a diagnostic mammogram and bill for the iodinated contrast, and it's more complex than that. Still should be much less expensive than MRI. 60 studies, 10,000 patients, 11,000 CEMs, very strong performance of CEM. This was the best study. The BRAID trial recently released their results, and this was taking patients and randomizing them to abbreviated MRI, CEM, or ABUS. We've been waiting for these results for a long time because this is really what we need to know. And what we've found that we expected, this is Fiona Gilbert's study, equivalent sensitivity or cancer detection rates with abbreviated MRI and contrast-enhanced mammo. ABUS is far, far behind. And then looking at invasive versus DCIS, it just highlights that the CEM is giving you both the detection of the calcifications on the mammogram as well as the vascular information. So we're having a higher rate in this study of DCIS detection and equivalent rates of invasive cancers. So I think the time has come for CEM to replace MRI. It is more accessible, it will be lower cost, but we have some work to do on CPT codes and support and training radiologists and making those very difficult transitions to let go of MRI and come over to CEM in the screening setting. MRI still has a role. And then it's the what and the who. We can do so much better than just using density from the mammogram, and we can do so much better than our existing risk models. There's a lot that we can do to be more precise in risk assessment so we can change the what and the who at the same time. I'm going to wrap up with a promising future for AI. Very fortunate in breast imaging that we have the history of CAD. It was approved in 1998, slow adoption until we started being paid for it, and then everyone was using it, but it didn't have the impact we wanted. We didn't see a translation from the early trials over into clinical practice. That was discouraging. And we may be at risk for repeating that story again because the AI tools out there for improved image interpretation are using 510K pathways that were exactly the same study designs used for the CAD adoption. Roughly 240 heavily enriched mammograms read with and without CAD by 1 to 2 dozen radiologists. That's a perfectly fine way to approve or clear the products, but we haven't seen that translate over into clinical practice, and we may repeat some of the same errors. What's really going to be exciting from those lessons learned is new applications of AI. And where that's going to happen is on our pathway to autonomous image interpretation. This is the pathway where more patients globally will have access to the life-saving benefits of screening mammography and a lower rate of false positives and the variation that we're currently seeing in screening mammography. Now, I had made that presentation at FDA in 2020. It seemed reasonable to think that. The father of AI had presented 4 years previously saying that surely deep learning is going to do better than radiologists. In 5 years, they will be replaced. You can imagine not all radiologists appreciated being compared to Wile E. Coyote running off a cliff, but that was the analogy. And so what happened was outside of mammography, we started seeing these shifts. And we had Viz.AI getting clearance from the FDA to triage CT exams to put patients more likely to have stroke or subdural hemorrhage at the top of the list. Mammography companies then use that same 510K pathway to say, couldn't we sort mammograms in the same way? Couldn't you put the more complicated ones at the top and the ones with absolutely nothing at the bottom? You could use that type of triage tool in many ways to improve the way we interpret scans. And then, of course, what was most exciting was when the FDA cleared the first autonomous AI in the healthcare setting. Interestingly, it happened outside of the imaging of radiology and in the domain of computer vision and retinal images. And this is now moving into images of the skin. This transition was extremely rapid. All the steps these companies went through to shift to autonomous interpretation of images, all of the steps in having, for example, the American Diabetes Association update its standard diabetes care to include autonomous AI for diabetic retinopathy. This is something that in the radiology sciences we need to think about. Can we see opportunities to expand the power of imaging and improve patient care and access through autonomous imaging interpretation? I think we absolutely can, and we will, because we have these brilliant, brilliant people who have done so much in their careers. Jeff Hinton lost not only his first wife, but his second wife to cancer. the father of deep learning, the winner of the Nobel Prize. Early and accurate diagnosis is not a trivial problem. We can do better. Why not let machines help us? Or the brilliant Fei Li, an immigrant from China who attended Princeton and is a brilliant professor in this domain at Stanford. The day healthcare can fully embrace AI is the day we have a revolution in terms of cutting costs and improving care. So I want to thank you for your time, and I look forward to our discussion. Thank you.
Thank you, Dr. Lehman, very much for that very, very nice and comprehensive review. Thank you. Our next speaker is going to be Dr. Seema Khan, Professor of Surgery at Northwestern University, talking about screening for high-risk women, the clinical perspective.
Thank you, Dr. Jatoi. Thanks for including me in this session. I have thoroughly enjoyed listening to my very accomplished colleagues update us about advances in both determining who should be screened, how they should be screened, what's available for screening. So I work in a clinical setting, and I'm going to try to address these issues from that aspect. And although I don't have any conflicts to disclose, I should clarify that I did not discuss any of these issues with either Dr. Kerlikowske or Dr. Lehman. So if you hear any similarities in our opinions, they were individually derived. So obviously there are multiple sources of risk for women who are concerned about breast cancer risk and who are at increased risk. I've attempted to show them here with some representation of the size of the attributable risk that Dr. Kerlikowske has covered quantitatively. But then in terms of managing this risk, there are also multiple aspects to the risk management that we need to think about. And today, though, as requested, I'm going to focus on the surveillance. So tailoring surveillance at the individual level has two components to it, both subjective and objective. And objectively, we can all agree that we need to quantitate the risk estimate for individual women. We need to identify women who are at increased risk. This is really the cornerstone of our management that's personalized. And for imaging decisions, I'm going to make a pitch against lifetime risk estimates. I've said this before, I think, here at this meeting, and move to shorter term estimates because they make so much more sense. And I hope we'll all agree on that all of us together here will agree on that. So, and then subjectively, of course, we're talking to women who have their individual concerns, their individual histories, and we have to take those into account. They've experienced breast imaging previously. Some of them have found it more burdensome than others. They may have experienced biopsies. All of that goes into their concerns when they come for a consultation about risk management. And they've also obviously received advice from other physicians who may not be well informed about these aspects, and they suffer from anxiety. So all of this goes into the recommendation. But talking about personalized recommendations, the discussion really goes back to the early part of this century. Dr. Lehman was part of that, where the American Cancer Society, looking at the increasing availability of genetic testing for susceptibility to breast cancer and the increasing availability of MRI, convened an expert panel to consider these issues. And these recommendations, I think everyone can agree on, at least the ones that are related to genetic risk. So BRCA1 carriers, their untested first-degree relatives, women with other high penetrance cancer, gene alterations, etc. The thing that we are living with now is this lifetime risk of 20 or 25% or greater being a qualifying feature for adding supplemental MRI, which was the modality under discussion at the time, defined by models that focus largely on familial risk. They also addressed the issue of women who were at lifetime risk of 15 or 20% and found that there was insufficient evidence at the time to recommend supplemental MRI for this group. But since then, the discussion about lobular carcinoma in situ, atypias, density, et cetera, has come a long way over the past 20 years or so. These are the issues that we need to deal with in clinic, but now we turn to the NCCN guidelines. These are guidelines from 2024. Well, NCCN or other bodies, of course, there are other similar bodies. This recommendation for residual lifetime risk of 20% or greater with models that focus largely on familial risk is still there. There are other, very sensible recommendations that we all follow about clinical breast exam, the time that the imaging, although the timing, I think, is something that should be looked at again, but at any rate, that's the current recommendation, begin 10 years before the youngest affected family member, where there is a familial risk, and annual MRI with or without contrast, with and without contrast, can replace CEM, or maybe, and I won't go there because we'll focus right now on what's most extensively used, which is MRI. And then, of course, the group that's lifetime risk of 15 to 20%. So the estimation of residual lifetime risk, and some of this is going to overlap with what you heard from Dr. Kerlikowske, but risk models that are largely dependent on family history, the ones that they recommend are listed here, BRCA-Pro, Tyrer-Cuzick, Bodacier, which is now combined in cancer risk, CAN risk. And they do touch on polygenic risk scores. I won't go there either because there's a lot of work going on. We need to see what how that really validates in a real-life setting, and they recommend, the NCCN panel recommends that we don't utilize these in the clinic. So that's just to complete that list. And then we have to acknowledge, of course, that these family history-based models don't really accommodate the breast-related risk factors, mainly breast density and atypia. So we do see patients who have particularly those risk factors, and we have to address that group too. So it's reasonable to stratify how we approach risk assessment, or risk estimation is my preferred description, actually, because we do need to convey that it's an estimate that carries an error, and we don't always understand the error, and I don't think we convey that to our patients well enough. But at any rate, the risk may come mainly from family history or mainly from breast-based factors. For family history, again, this part is pretty non-controversial, but many women who go for genetic testing don't have genetic susceptibility identified, and in that case, they're still at increased risk because of the family history, and we do need to estimate their risk and make a recommendation. And the Tyrer-Cuzick is a widely available, well-validated model that may do that, but I'm going to talk also about the BCSC, and I didn't talk to Karla about this ahead of time. So for women with breast-based factors, I think these other models do better. GALE was the standard tool. We have really switched entirely to BCSC. For extreme density, we do recommend, without other risk factors, supplemental imaging based on the DENSE trial, but I think there's certainly room to question that. There is also, extreme anxiety among clinicians in general about what if this patient is diagnosed with breast cancer next year and we didn't recommend an MRI for their extremely dense breasts, where will we be? So that, unfortunately, is sort of the elephant in the room many times. So talking about the BCSC then, you've already heard about it. I won't spend time on this, but I think in our community, certainly in our center, we have fully embraced the BCSC model. It is very easy to use. It has a very nice visual, I'll show that in a minute. But just to compare it, so it has a very nice visual display, which I also like and is easy to discuss with patients. But the other model that is available for the same purpose is the Tyrer-Cuzick, and this is the American data on the Kaiser Permanente cohort, a very large data set, over 100,000 women aged 40 to 73, and mostly white, mostly urban, with a median follow-up of 5 years. So what I wanted to show here is how the confidence interval increases as you go out in time. So all of the discussion in this paper and in other similar papers, everything we heard earlier today was about 5 and 10-year risk. So in the sort of published data, there's very little discussion of the validity of lifetime risk estimates. And you can see here how in the highest risk category, 8% or higher, the confidence intervals really do blow up, and they get, when you add density, the confidence intervals widen even more. So that's, again, something to remember, and another reason for not really going out into the long term in terms of recommending interventions to women where the benefit of the intervention is probably a more short-term benefit of detecting cancer. This is the visual display I was talking about, and Dr. Kerlikowske showed it to you, but it's actually on our screens it comes out more like this, where it's really, the distribution is wide, it shows the whole population, and you can see the distance between the blue line and the red line. So when I'm trying to convince women that they should seriously consider drugs for risk reduction, this is actually a very useful thing to show them. It helps the discussion greatly. In this woman that I calculated this for, she's very high risk, she's mid-40s, has both atypia, two affected relatives, she's overweight, she has extreme density, everything thrown in. Her 5-year risk was 6.5%, her 10-year risk was 13.8%. And when the same profile was plugged into IBIS, it was very similar. So when we use shorter risks, and there's actually a nice paper that was published in JNCI by Connie and colleagues a few years ago that actually compared Bodicea with IBIS and showed that if you use 10-year risk estimates, the concordance of who's identified as being at high risk is very similar, but if you use lifetime risks, there's a big disparity between Bodicea and IBIS, and I think that would probably be true of other organs too, other models too. So the shorter risk timeframes are also more concordant across estimates, and it reduces confusion for patients, because we often see patients coming in who've seen other practitioners who have widely differing estimates for their breast cancer risk. So Connie talked about this already. I'm equally excited about this. I think this is where we need to be going in terms of risk estimation, because so much of the information in these models comes from that mammogram, which is not subjective. Once it's been put into the image, you can go back to that mammogram and it's always there and looks the same way, right, Connie? Yeah. So with familial factor, family history does change, of course, but the way that that individual risk factors are entered into risk models, particularly in IBIS, we find this in Kerlikowske, different practitioners come up with different estimates sometimes based on interpretation of how the questions should be answered. So I'm going to only show you 2 studies, but you've seen this already. This is the validation study from the Karolinska group, Michael Erickson and colleagues, and they've compared the output of their profound AI model to the Kerlikowske, and you can see there's a big difference favoring the profound AI, particularly in the beginning, but even at the end of 10 years, the profound AI performs better than the Kerlikowske. And then this is the Mirai model, which also has been validated extensively in this data set, again, published only 2 years ago. Large number of screening mammograms from 7 different international sites, and compared to the Kerlikowske, consistently showed an AUC of 0.7 or greater. And the thing that really interested me was also that the C-statistics was approaching 0.9 for sites that were using biennial imaging. So all of the advantages that you've heard about from Dr. Kerlikowske about biennial imaging, I think we really need to take them seriously and apply them to our practice and to in our conversations with our patients, because patients get anxious about not having mammograms every year. They've been told for decades they need mammography annually, and so they get very anxious about it. I think radiologists do as well. about doing biennial. That's why our site, Northwestern, is not participating in the TMIS trial, because for older women, it recommends biennial imaging, and our radiologist decided that that was not appropriate. So, so there's a lot of variation in the acceptance of this information, but you know, we just need to get the message out there that needs to be taken seriously to minimize the harms, as you've heard. So this is the accompanying editorial for the Mirai study. I just took the title from the publication. Lars Grimm and Jennifer Plichter and Shelley Huang wrote this editorial, and they called it More Than Incremental. And I think that what we've seen of the performance of these tools so far would really support that. So you can see here in the editorial that they compared the AUCs of the classical models and the Mirai model, both in the initial publication and now in the validation study, and it really appears superior to the others. So this is a very exciting direction for us. So then, you know, of course, as clinicians, we have to ask and discuss with our patients whether MRI surveillance alters clinical outcomes. And I think there are 3 clinical outcomes to think about. One is downstaging, and MRI certainly does that. We have data to support it. Does it decrease the burden of treatment for detected cancer because the cancers are earlier at the time of detection? It probably does that, but I don't think it's been documented as well as the downstaging effect. And then finally, the survival following treatment. And you heard how we have really improved treatment over the past years and how the value attributable to screening has diminished as the treatment efficacy has improved. So that ratio is going to continue to shift. But still, you know, in the clinic, we realize that even though you may tell a woman that her risk of developing an advanced cancer is low, she would still want to avoid the small cancer, or also, I mean, that belief that finding a cancer when it's small is so embedded that it's hard to persuade women that a small change in size is really not going to change their treatment. So I think we need to document that. But the survival data are still fairly fragile. So these are data from the FAM risk study from the Netherlands, women aged 30 to 55. They had a cumulative lifetime risk of greater than 20% based on familial factors. They looked at survival in the long term, 1,300 plus women who were randomized to MRI with mammography or mammography alone. And the mammography in the MRI group was biennial because they wanted to reduce the number of overdiagnoses of DCIS. These are their data on the detection. So big difference in the incidence screen, not as big a difference in the prevalence screen, but still MRI outperforming mammography. And you can see the stage shift here. So for node positivity, in the bold red at the bottom, 17% with node positive cancer in the MRI group and 63% in the mammogram group, and that was significant statistically. The difference in size was not as significant, it was just borderline, and it was driven, I think, mainly by this T1C category, which is 29% in the MRI group and 63% in the mammogram group. So downstaging has been shown, stage shift has been shown in many studies, and MRI clearly accomplishes that. Whether it saves lives is the next question, and this is again the MRISK study. And although there is a difference in the survival of women whose cancers were detected with MRI versus mammogram, the number of events you can see is very small. So in the BRCA1 carriers, 3 versus 9 events. In the familial risk category, 2 versus 9 events. So I don't think we can hang our hat or anything else on that, but still, you know, going in the right direction. MRI surveillance in BRCA1 and 2 carriers was looked at recently by this hereditary breast cancer clinical study group led by Stephen Nerod in Toronto, and this was published this year. So they have a cohort of 2,500 women with BRCA1 mutations, variants, pathogenic variants, and from 11 countries. And they were enrolled over a long period of time. They do have a follow-up of about 8 or 9 years, and the outcomes were collected through questionnaires. So they didn't receive much treatment that would reduce their breast cancer risk after they were enrolled. So 15% had risk-reducing mastectomy, and only 5% or so used SERMs. Oophorectomy use was more frequent. The death rate in this group of patients was relatively low. Breast cancer is a treatable problem, even in women who have genetic susceptibility. So 3% in the no MRI group and about 1% in the MRI group. And here are the numbers. So for the BRCA1 variants, their hazard ratio was 0.2, very significant. For BRCA2 variant carriers, there were fewer cancers, there were fewer women, there were fewer cancers, but the hazard ratio is close to 0.9. So I'm not sure that this is really going to turn into a significant survival advantage even as the numbers increase. And I think that this tells us a little bit about this issue of vascular imaging and the kinds of cancers it picks up that mammogram doesn't pick up. So the BRCA1 carriers, as we know, have a very high propensity for triple-negative disease, highly vascular and high grade and so on. And the BRCA2 carriers develop cancers that are more similar to the general population. And so this has some implications in my mind anyway, and we can discuss it, as to whether for those other non-genetic risk women where we've been considering MRI, whether we will see a survival advantage because their cancers have, on the whole, a different biology. So the costs, a couple of minutes finally on the costs of supplemental screening. You've heard about this already, but I just want to talk about the high-risk population because this is a study that looked specifically at risk perceptions and burden of worry and anxiety in these women. So they looked at the actual and perceived risk, the trait anxiety. They used a standardized tool for that and classified high anxiety as those women who were in the upper quartile of the distribution. They also looked at numeracy, which is a problem too in our population, and breast cancer worry. They enrolled 162 women, and a third of them were high risk by risk estimation. And they perceived their life, about 51% perceived their lifetime risk to be high. And trait anxiety was high in about a quarter. So perceptions were always, as we've seen in other studies, that women perceive themselves, women who are objectively at lower risk perceive themselves to have much higher risk. So there was not much difference in the perceived risk, despite the difference in estimated risk. And then the burden, the quality of life burden of both the additional imaging and the recall with biopsy was actually not influenced very much by their risk group. Low-risk women and higher-risk women had similar quality of life impact. What did affect the quality of life was their trait anxiety. So again, you know, this is talking time in the office and something that we don't always have room for in our schedules, but this is also what reassures women and sort of decreases overutilization of tests of all kinds, I suppose. So in the general population, this has been looked at by Heidi Nelson and colleagues. This is a systematic review. And they also quantified the risks for both annual versus biennial. So I think you've heard this message already, and I won't spend time on it. But it does, false positive results do cause anxiety, distress, etc., although the results are somewhat variable. So cost effectiveness, this is another important thing to look at. And the investigators of the DENSE trial actually did examine this and came up, I won't go into the details, but they came up with the conclusion that alternating mammography and MRI every 2 years brought us close to the efficiency frontier with loss of, with a difference in breast cancer deaths of maybe 1 or 2 per 1,000. So that is something that should be tested prospectively, in my opinion. So in conclusion, the quantitation of risk should precede risk management advice. It's advisable, I think, to select the tool that aligns with the risk profile and also to align the time frame of the risk estimate to the duration of the benefit, which for screening is a relatively short benefit in the matter of years rather than decades. So, and advanced imaging obviously is better informed by short-term risk estimates. That's why we're all talking about 5- and 10-year risks. And this is my final recommendation for future studies, is we should consider biennial MRI in the populations where we are recommending supplemental MRI. But if Connie, brings fruition to the contrast enhanced mammography, maybe we won't be talking about MRI. So thank you very much for your attention.
Thank you very much, Seema, for that very, very nice overview. I know you did that on a short notice, and thank you so much for doing that. Thank you. So as we were getting questions, I was just going to ask a question to the panelists. This is, taking the prerogative of the chair. The initial 9 trials on mammography screening had mortality endpoints. Since those 9 trials, we're undertaking lots of trials, lots of studies, with tumor detection as the primary outcome measure of interest. The tumor detection is the primary endpoint. How confident are we that tumor detection is going to translate to a mortality decrement? In other words, finding more tumors is going to lead to reduced mortality. How confident are we that tumor detection is a proper surrogate outcome measure for mortality? I know Karla mentioned advanced cancers, and I think I'm kind of more inclined towards the advanced cancer, but I just want to get a quick discussion from the panelists regarding that question.
Yeah, I didn't include that slide. Should have. But if you look at SEER and you look at early stage cancer versus advanced versus mortality, early stage does not track with advanced cancer. So I am not convinced that detection is what we should be using. I think that we should be using, advanced cancer, because that's what tracks with breast cancer mortality. And incidence does not, and in particular early stage does not. I can share that slide with anybody if they want it.
I totally agree with Karla's perspective. I think that we need, when we can't do mortality endpoints because the technology is changing. We just have to wait too long. So we need to have the metrics that we agree on that are reasonable goals. And we have to balance the goals for benefits and the goals of the risks. How do we keep the risk down? And Karla, I think that's one of the things you stress so much is you always have to pay for something. So whether it's, as you reviewed, anxiety, cost, false positives, others. But I do think that advanced cancers, and also interval cancers. Interval cancers are tricky because it depends on what they're being screened with. You add MRI into a screening population, your interval cancers go way up.
Exactly, so. Yeah, I think interval cancers are tricky because it all depends on how you define it. Where if you just do advanced cancer, it's easy. Screen detect interval, it's sort of, it's basically the same with both, so it makes it easier. I just want to say one other thing about false positives. Sorry I didn't include this slide either, but I know people tend to talk about anxiety, but we had an article published in the Annals of Internal Medicine a couple months ago maybe, and we looked at return to screening. And what was interesting is if you had a false positive, and particularly a short interval false positive or a false positive biopsy, you were less likely to return to screening. And this kind of bothered us, right? Because we know that, benign biopsies are a risk factor for breast cancer, and these are the people that aren't going to come back if they have a false positive biopsy. So I agree the anxiety is a big part of it, but also there's some concern that they're not going to come back for screening.
So we had a question online. It's an online question. We are having trouble getting MRI studies due to insurance. What do we do? Does anybody want to tackle that question?
It's a terrible situation. So all of this discussion about supplemental imaging, there is such wide variation across the country, state by state, in who will pay and who won't pay, and even the expression who will pay varies, because for a woman to be told her insurance will cover it, but she needs to cover the deductible or the copay, it makes it cost prohibitive for her to engage in that. I think that's why we see these studies where the vast majority of women who would be eligible by guidelines for MRI are not undergoing it. So it's a challenge. I'm sure you deal with it a lot in getting payment.
Yeah, we deal with it a lot, but I think the other aspect of the copay, which I agree is a real burden, but it's particularly a burden for younger women because they don't have the health problems that lead to them meeting their deductibles. So their deductible then comes out of their MRI cost, and it really is, a burden for them. And that's another place where I find explaining to them that this lifetime risk estimate is not the right threshold for, or the right metric for recommending MRI or considering MRI is because you have a 35-year-old woman, her lifetime risk goes past 20% with very minimal real risk. Whereas you have a 65-year-old woman who probably has a much higher short-term risk, and her lifetime risk is going to be shorter because she has, less time to live. So it's completely irrational, and I'm sorry to say that to you, Connie, because you were in the original group that used the...
Yeah, but we can all change our minds.
Okay.
So I am completely on the bandwagon.
Can I ask both of you?
It's the short term, it's the 5 and 10 year risks, and we're working on a paper just to say it's time to stop the 20-year, the lifetime. It's time to stop, and the more we study it, the worse it looks.
Yep.
Well, and actually the ACS, the word on the street is they're changing their guidelines and they're not going to use lifetime risk, which is good. But my question to both of you is that, abbreviated MRI technically should cost less, but there's not a CPT code for that to reduce the cost. And I was thinking insurance companies might embrace that if it was at a reduced cost. So why isn't there a CPT code for abbreviated MRI?
Yeah, it's been uncomfortable to watch that transition because people that were saying this is great, we're doing abbreviated MRI, it's so much less, patients are paying out of pocket for it. So that already then instills inequity in access. So that's a problem.
We'll take the first speaker there, the first question.
Hi, my name is Stephanie. I'm from Kingston, Jamaica. I'm a surgeon. I wanted to find out from you, in terms of the Black population in the BCSC and the modified Gale and so on, how did you find the subgroups in the Black population would perform with that risk tool, like the Afro-Caribbean population, for example? And also, for me, if you would recommend that I use in my population the BCSC or a combination of BCSC with Gale, which is something I've been doing in terms of risk stratification. And also, if you would recommend, I think it was the second speaker at all, if we could use contrast or CEM in lieu of MRI in a resource-restricted country. Because I've been using MRI to screen my high-risk patients, but it's costly. So if I could offer them that instead, it would be amazing. So just a question for that.
So I'll answer the latter part, and then you go ahead. So I'm very hopeful that CEM is going to have greater and greater access globally. I think we need it in the U.S. and we need it globally. The upgrades for the mammography equipment and the ability to perform CEM is a tiny fraction of what's needed to establish an MRI program. So I'm hopeful for that, but we've got some work to do because there's just a lot of resistance to letting go of MRI when people have really become so accustomed to it. I'm going to let Karla answer your other question. In our studies of the Gale and the Kerlikowske, our studies have been performed in patients that self-report identifying as Black, so we don't have the subgroups within the self-identifying as African American or Black that we'd like to have to be more sophisticated about those assessments. But in those, we have not found in a very large population in Massachusetts of our patients that self-identify as Black, we haven't found that either the Gale or the Kerlikowske perform at a level that you'd want to be using it clinically in your patients of color. So it just doesn't perform.
I mean, similar for the BCSC, it's, as I mentioned, it's people across the United States. So it's that population mix that represents the US, and it is self-report. It's how people identify their race and ethnicity. We do tend to look at, you know, Black, non-Hispanic, Black, Hispanic, so we do take that into account. And in particular, like, this has happened twice to us now with the BCSC V3 model, risk prediction improved in Blacks by adding BMI. It improved quite a bit. So I don't know about trying it in a Jamaican population. It sounds good to me. In our advanced model, we're actually doing an analysis now. There's, you know, all this thing about whether you should have race, ethnicity in the model. You know, we found our model doesn't perform as well without race and ethnicity, in particular for Black women. So I think both the BCSC and 5-year invasive model and the advanced model work well across, you know, across the different races.
We'll take the question from on the right.
Dan Morgenstern, Hartford, Connecticut. When it comes to screening familial risk without pathogenic variants and say in a pedigree where there's not particularly early penetrance, the best way I can ask this question for MRI screening is what's the sweet spot? Because we get referred with more and more genetic testing, we get referred more and more patients that walk in with TC scores with their cumulative lifetime risk of 21%, but they're 30 years old, and their 5-year interval risk is 0.5%, less than a 40-year-old average general population. So the first part of the question is when's the sweet spot to start in such patients? And then on the other end, as you mentioned, as risk gets exhausted as you get older and your remaining residual risk in your 60s starts to wane, when is the time to stop? Sorry.
Yes, so I think that the best way that I have found of avoiding these questions for younger women is to persuade them that the lifetime risk estimate is not a valid way to assess the value of MRI surveillance for them. And so, again, it takes about at least 10 minutes of talking on that specific point, but I have found women very willing to accept that argument. So once I've been through the pros and cons of using the long-term risk versus the shorter-term risk, they're very amenable. Now, I would like to use the NICE criteria of 8% 10-year risk, but I'm too chicken to do that, I guess, in the American environment, so I use a 5% threshold. But even with the 5% 10-year risk threshold, I find that we can avoid MRI recommendation for a lot of younger women who really, have just enough to push them over 20% lifetime, but they really are not at high risk. So that's how I deal with that question. My colleagues don't really, everyone is nervous about not following NCCN guidelines, right? So that's the problem. And then the second part about when to stop, there isn't really any good criterion that's across the board for all older women. I think it depends on chronological age and, physiologic age. But I think it's something that we need to start broaching to women. I find very few women are actually offered the option of stopping screening when they get into their mid-70s or close to 80. And they're surprised to hear it if you broach it for the first time. So if we just make it a more talked about topic, both in our own conferences and with our patients, it'll just become more acceptable that it's reasonable to think about stopping screening.
And would you apply different principles for risk lesions in terms of those ideal times versus familial risk negative germline testing?
Well, familial risk germline testing, if someone doesn't have an alteration, the familial alteration, or the family doesn't have an alteration, by the time they get into their 60s or 70s, if that gene was going to express itself, it probably would have by then. I think that's sort of hand-waving to some extent, but still, without other guidelines or other sort of data-based reasons to recommend this, I generally use why don't you go ahead and continue your mammography for another 5 years if you've had an atypical lesion found recently?
Thanks.
So we have a question for Dr. Lehman. Dr. Lehman, any progress on screening technologies that don't require breast compression?
Not really, honestly. There's some domains that are working on less compression and being able to stabilize the breast without that real flattening. And I do think in the domain of vascular contrast-enhanced mammo with DBT really begs the question, why are you still compressing so much? We actually don't really want to compress with either the CEM or the Tomo sweeps because you have more of the tissue, in its natural state. So I think we can move towards that, and we certainly are very aware that we'd like to have, if not no compression, stabilization and significantly less compression. So I think that that's going to evolve with the continued evolution of tomosynthesis and contrast-enhanced mammography.
So this kind of gets me back to that question we talked about earlier about tumor detection endpoints. Why not trials with quality of life endpoints? I mean, there are certain screening interventions going to result in better quality of life. Why not design trials with quality of life endpoints in screening? Because this is a question that comes up all the time. The anxiety, the pain, the discomfort of screening. If there's technology that's better, it would be more readily accepted. So that as an alternative to tumor detection endpoints might be considered.
I think it's a fantastic point because it does mean that we have multiple metrics that we're interested in on the patient's experience. So they're, advanced cancers, the patient experience, patient acceptance. So we've done the studies and we know that patients appreciate having a CEM significantly more than having an MRI, even though there's compression with the CEM. So it's a really important point. Certainly the impact downstream of recalls for patients without cancer. I think that's also very important. So we do try to take multiple metrics of what our goals and our endpoints are and then balance those. And it depends on the patients. I mean, I'm always impressed by some patients that will do anything if there's a chance of finding the cancers, and others really, and Karla is always so eloquent in talking about this, Karla sees a lot of patients where it's been the negative impact of those unnecessary biopsies, that anxiety about the 6-month follow-ups, that's really influenced the way they see their bodies, the way they sense their health. So important points.
I realize there's a question there. I have one for Karla, though, which, is going to, it has to do with this advanced model, the BCSC advanced cancer model. So I've looked at that, I've used it for some patients, and the estimate comes out so much lower, which it should, right? But it's very hard to apply that much lower risk to any of the recommendations that are out there for supplemental imaging or for risk reduction for that matter, right? So I think we'll have to find other thresholds for those interventions if we're going to go with the advanced cancer estimate. The numerical estimate is lower.
Well, yeah, the risk of advanced cancer is low. So the thresholds are based on the lowest risk is less than 5%. Low is 25 to 50, I think, average. So it's all based on that, and that the highest is the top 5%. So even though the numbers are low, it's based on the top 5%. So if it says high, it means they're in the highest risk category for advanced cancer. And it really is, again, it's called an actionable model. It's really trying to help you say, should I screen annually or biannually? Or there's some people that really should get annual, and then the whole supplemental imaging. But that it's really
It's the percentile then that we should look at.
It's based on the percentile. Even though the numbers look tiny, because advanced cancer is low, it's really based on, thresholds of percentile.
Okay. All right. So
and as far as chemo prevention, I mean, the U.S. Preventive Task Force recommends the BCSC 5-year invasive cancer model greater than 3% to recommend primary prevention. So I think primary prevention, use a BCSC 5-year invasive model. Screening, frequency, and supplemental imaging, use the advanced model.
Okay.
We'll take the next question. Yes.
Hi, Carol Tweed from Annapolis, Maryland. We're fortunate to have CEM rolling out in our community. And my question is about those patients of mine who are moderate risk enough to discuss supplemental imaging, but perhaps also young, presenting with a question of the radiation exposure concern, and what you could tell us about that and how we could frame that discussion.
So the radiation dose from a contrast-enhanced mammogram is 20% more than a regular mammogram. So it's the low and the high energy, combination combined together has a very small incremental uptake. It's well below the recommended threshold for acceptable radiation with a mammogram experience.
Okay, so you would just discuss no overt concern about cumulative exposure over the years?
Right.
Okay, and the other question I wanted to ask, please, is there a role in your practices for use of the Mayo predictive model for the patients with atypia? Does anyone use that, and if so, how?
I don't. I think that it's a model that was developed in an institution that has a very large cohort of those patients. I don't see that it adds a lot more to a model like the BCSC, for example. The lack of validation is a concern.
And both BCSC models have benign pathology. Mm-hmm. So you can put in, ADH, LCIS, and we're actually probably going to maybe update that aspect. We have a PhD student looking at things like papilloma. If you have a papilloma and a calcification, does it increase your risk? So, but the basic pathology are in both models.
Fantastic, thank you.
We'll take the question from the far right.
Hi, my name is Jade Moran, and thank you so much. I'm a patient advocate. I actually just have a comment about the issue of false negative versus false positive. I have metastatic ILC, lobular cancer, and mine was missed even though it was visible. And the issue of false negatives versus false positives has an unequal effect on the people who get false negatives. There are studies that show that people who get false positives, yes, they have stress, they have effects, but the people who have false negatives have lasting trust problems, and that it's really undermined the relationship with their clinicians and their sense of security. I learned recently about a term called illness insecurity. So I just wanted to put a little plug in there for keeping that in mind. They're not equal. We shouldn't look at them equally. Thank you.
Yeah, absolutely, and we appreciate that, and it's for all of these different metrics we look at, there's different weighting and balance, but thank you for sharing that, such an important message.
So thank you very much, and that concludes our session. Thank you.